Good evening, viewers. Welcome to another Friday episode of Experts Appraisal on Emergency Medicine in association with Anbai and Semi. Today we have a young and dynamic speaker, Dr. Pranay Penmetsa, who has done his master's in emergency medicine from D.Y. Patil Medical College. Though he has 3 years of experience in the emergency medicine, he has contributed significantly to it by publishing multiple papers and has done enough research. So his areas of expertise include point of care ultrasound, emergency airway care. Then he is an expert in treatment of acute stroke and taking critical care decisions. So today he'll be talking more about thromboelastography, which is commonly called TEG. So TEG is a critical part or a test which is usually not yet much flourished in India, which is in the emergency departments, but abroad it is being used relatively consistently. So he'll be talking more about the use of TEG in emergency department. So I welcome Dr. Pranay. Please take over.
Thank you, Dr. Ranjit. Good evening, esteemed faculty, consultants, and residents. Today, I have the privilege of talking on the topic of thromboelastography in the emergency department. So, no financial disclosures and no conflict of interest before I start my presentation. The outline for today's presentation will be an introduction and background of thromboelastography, the principles and mechanism, how to interpret the graph of TEG, uses in ED, limitations, few references, and some takeaway points in the end. Maintaining blood in a liquid state is essential for homeostasis as it ensures the delivery of sufficient oxygen nutrients. Conversely, the ability of the blood to convert from liquid to a solid state, that is basically coagulation, underlies the mechanism that protects the body from life-threatening exsanguination. These unique properties of blood are largely determined by a complex and active balance between procoagulation, anticoagulation, and fibrinolysis. So the commonly used coagulation studies that we do in the ER include prothrombin time with INR, activated partial thromboplastin time, platelet count, fibrinogen concentration, D-dimer, whole blood bleeding and clotting time. Now the problem with these tests include platelet count specifically, because platelet count, despite the count being normal and we assume that the platelets are normal while the patient is bleeding, patients can have underlying problems like uremia, or maybe patients are on antiplatelets, which will harm the function, which will reduce the function of platelets. So despite having a normal platelet count, and if the patient is sanguinating, it is not of much help. As always, with prothrombin time, if the patients are on anticoagulants like acetron, it will give us a very high value. D-dimer levels are false positive in majority of the cases, so we have to take it with a pinch of salt. Now, if we want to combine all of these into one single test and have a point of care test that can be reproducible, we have TEG. So coming to thromboelastography. So thromboelastography is a promising diagnostic modality that offers several advantages compared to standard coagulation studies. It was first developed in 1948 by a German doctor by the name of Helmut Artet at the University of Heidelberg. The first reported clinical application of this test occurred during Vietnam War in an attempt to guide transfusions of blood components in injured soldiers. It is a non-invasive test, quantitatively measuring the ability of the whole blood to form a clot. The reasons why it had fallen out of clinical practice from 1948 is because of the technological limitations. The earlier TEG machines were very mechanical and were subject to very vibrational changes, which will give a very false reports. Also, the lack of clinical correlation and understanding at the time, followed by an inability to understand the TEG graph, has been a reason for its falling out of favor since 1948. Along with that, we have a rise of simpler blood tests like our platelet count, INR, APTT, and clotting time, which are easier to perform and standardize in central labs. But of late, it has been seen a revival because since 1980s, the technology has underwent significant advances with introduction of computerized and disposable tech systems like the ROTEM, recognition of coagulopathy in trauma, liver disease, cardiac surgery, where standard tests failed to predict the bleeding risk. It is a point of care test and it can be reproducible and can be acted upon on frequent intervals. Also, of late, there is a strong evidence for guiding transfusion protocols, reducing the use of blood and blood products since they are not of since they are limited supply, and also using tech and tech-based blood product usage has improved outcomes. So the principles of TEG would involve TEG measures the physical properties of the clot in whole blood via a pin suspended in a cup. It is heated to 37 degrees and from a torsion wire connected to the transducer. The transducer will spin at a set frequency, and the elasticity and the strength of the developing clot will form an electrical signal which will be represented in a graphical form. It can be repeated easily and compared and contrasted and can be acted upon. So what sample has to be taken? It has to be taken in a 3.2% buffered sodium citrate plastic vial or a vacutainer. A volume of around 340 microliter of citrated blood has to be recalcified with 20 microliter of 0.2 molar calcium chloride, and then it is activated by a kaolin-cephalin reagent. We can use whole blood or the native blood, and that procedure would be called as NATEM. But if you are using NATEM, then the sample has to be sent to the lab as soon as possible because the clotting might have started and we might get an erroneous value. Coming to kaolin, it's a mineral primarily composed of aluminum silicate that can initiate the intrinsic coagulation by activating factor 12. So coming to parameters, so we have the R time, we have the K time, alpha angle, MA, which is the maximum amplitude, and LY30, that is the lysis at 30 minutes. So if we move on to individual components, R time is the time of latency from the start of the test to initial fibrin formation. It is the initiation phase of the coagulation profile, and it is dependent on clotting factors. So it is a test for both intrinsic pathway and as well as the extrinsic pathway. Coming to K time is the time needed to reach a certain level of clot strength, which is an amplitude of 20 millimeter. It is the amplification phase and it is dependent on fibrinogen. Coming to the alpha angle. Alpha angle is the slope of the line between R time and K time. It measures the speed at which fibrin builds up and cross-linking taking place, hence assessing the rate of clot formation. Thrombin burst, it's a propagation phase of the coagulation profile and it is dependent on fibrinogen levels. Coming to MA, which is the maximum amplitude, that is the ultimate strength of the fibrin clot that has been formed during the coagulation profile. It is mostly dependent on platelets and fibrin interacting via the GP2B3A receptors. Then we have the LY30, that is the amplitude of the amplitude at 30 minutes, which is indicating of the fibrinolysis phase. So as I said, the R time is the time to initiate the clot, which is basically dependent on the clotting factors. If the R time is prolonged, then the patient is hypocoagulable. And if the R time is shortened, then it is hypercoagulable. In such cases, if the R time has been prolonged, then we have to consider administration of fresh frozen plasma. Coming to K time again is the time required for the clot to reach a specific amplitude of 20 millimeters. It is the fibrinogen cleavage phase and fibrin polymerization, that is the formation of cross-linking fibrin bonds. Again, the delayed K time This means the patient is hypocoagulable and patient might require fresh frozen plasma to replenish the clotting factors. If the alpha angle is low or the K time is high, we can consider giving cryoprecipitate or fibrinogen. Coming to maximum amplitude, that is the fibrinogen activity and platelet count, which is again, if the alpha angle has been reduced, then the patient is hypocoagulable and patient can continue to bleed. And if the alpha angle is increased or if the maximum amplitude has been increased, then the patient is hypercoagulable and patient is forming clots. If the patient is if the MA angle is reduced, if the MA size has been reduced, then the patient might require platelets. Finally, we have LY30, that is the lysis percentage at 30 minutes. And if it is reduced, then we have to consider that the patient is in the fibrinolysis phase of the clot and might be beneficial to give tranexamic acid. These are the few important graphs of TEG that we need to remember, which includes the normal, which looks like this: a small R time, a steep alpha angle, K time is reduced, and a maximum amplitude, which is all normal. Now, compared to this, if the patient is hemophiliac or if it's if he's on anticoagulants, there is obviously some amount of factor deficiency. So, since factors are the first part of the thromboelastography, so the R time and K time are prolonged. In such cases, we might have to consider giving fresh frozen plasma or cryoprecipitate. Coming to if the patients are on beta blockers, like thrombocyte, or if the patient is thrombocytopenic or thrombocytopathy, in that the initial R time is usually normal because R time is mostly dependent on your clotting factors instead of the platelet count or platelet function. The K time may or may not be prolonged, but the maximum amplitude is decreased. This is because maximum amplitude depends more often on platelet count than on clotting factors. If the MA has been reduced, that would show that the patient has thrombocytopenia, or maybe the thrombocytes are not adequately functioning. Maybe patient is on uremia. In such cases, platelet transfusion is beneficial for these patients. Coming to fibrinolysis, imagine the patient is in the fibrinolytic phase of coagulation cascade, or if we have given fibrinolysis, as in streptokinase, tissue plasminogen activator, maybe for strokes or acute STEMI, then the R time is normal, the MA has been significantly reduced, and the LY30 has come down. Finally, we have hypercoagulation. That means we have R time and K time that are decreased. The MA angle has completely increased. Finally, we have the most important DIC, where we more often than not use TEG. So DIC, we have both. It can be hypercoagulable or hypocoagulable. In hypercoagulable, the graph will be a short R time, a very high MA, and secondary fibrinolysis happening with LY30 slowing down. Or hypocoagulable form of DIC, where R time and K time are extremely prolonged, alpha angle is reduced, and maximum amplitude has also reduced. So coming to uses in ED, of late, there has been a study that was done in AIIMS Delhi as well, where they have used TEG to early identify trauma-induced coagulopathy, where they had found that early use of TEG has shown them that there was prolonged R time and K time, where they could identify it as trauma-induced coagulopathy in a trauma patient, and they could support him with cryoprecipitate or fresh frozen plasma. Then it also helps in guiding transfusion and hemostatic resuscitation in the ED. It optimizes transfusion and reduces the exposure to unnecessary products. Blood products are very rare, and we cannot over transfuse because we might have shortages of required blood products. And also, if we transfuse too many blood products, it can lead to transfusion related illnesses. It also helps in identifying specific hemostatic derangements. In a study that was done in the setting of postpartum hemorrhage in the ED, a recent study showed that TEG could early predict hypofibrinogenemia in ED patients with PPH. This was a more recent study that was done in 2024. It has a faster turnaround time because your standard coagulation profile usually takes around 1 hour to 1.5 hours, depending on centers to centers. So take usually you can get the report within 15 to 30 minutes. So in such patients, if the patient, we will have a better idea if the patient is in the bleeding phase or in the clotting phase or the lysis phase. Depending on that, we can consider giving antifibrinolytics, blood products, cryoprecipitate, factor assays, and etc. Now, the most important thing is the limitations of late that we have seen of using tech. So first of all, it has been we have used platelet counts INR as of late because since 1980s the test is still operator and interpreter dependence. It requires trained personnel to run and interpret the results accurately. And as always, there is inter-observer variability among ED physicians who are new to tech. Sampling handling is another major issue that can distort results. And any amount of vibration or movement sensitivity, which is obviously common in our ED settings, can affect the tracing that is seen on the tech graph. It does not fully assess platelet function with von Willebrand disease, factor 13 deficiency, and individual factor deficiencies, von Willebrand level deficiencies, or patients on oral anticoagulant DOACs are not well reflected on tech. It also cannot precisely quantify fibrinogen concentration, but only gives functional assessment. Although the test is faster than standard lab coagulation profiles, it takes 10 to 15 minutes of setup and run time, which may be too long for a crashing patients. Availability in many EDs in India is very limited, and it may require lab or ICU collaboration. Associated with that, there's obviously the consumable costs, like cartridges, quality control, that can limit the widespread ED deployment. Since 1980s, since 1948, once we started using our standard coagulation studies, the use of tech had come down. So we don't have clinical evidence or clinical utility and the utility of tech. Only off late from the last 1980s to 2000s have we started using tech. And more often than not, the tech has been used in cardiac surgery and liver transplantation and not in general ED population. There are very few RCTs, especially in the ED-based massive transfusion or sepsis pathways. Tech should complement, not replace, conventional labs. Blind reliance can delay essential transfusions or interventions if results are misinterpreted. Along with these are other limitations like technical handling, cost, low sensitivity, low specificity, device variability, and workflow fit. It can lead to adoption barrier, difficult to standardize, misuse risk as well. So these are a few of my references. Finally, the take-home points. It is more research needs to be done in the use of tech in the ER because it's a very reliable test. It does not obviously, it is used to complement our platelet standard coagulation profile, but it also gives us valuable information if the patient is in the bleeding, in the clotting phase or in the lysis phase. So the simplest graph would be if you have an increased R time, you have to always consider fresh frozen plasma, decreased alpha angle, then consider cryoprecipitate, decreased maximum amplitude, then platelets, and if the LY30 is reduced, then tranexamic acid. These are few of the graphs. If you're new to tech, then if you use these graphs, you have a better idea as to how we can proceed with using with our blood product consumption. Thank you, and I yield the floor.
Thank you very much, Dr. Pranay. So it was a brief but clearly well described tech. Basically, not many of the emergency physicians or many of the doctors are aware what is tech and ROTEM. So particularly tech is commonly used in the ICUs or during transplants where they require time-based, where they have to take time-based critical decisions based on what they are losing, where the patient is losing blood or she's losing blood during OTs or during transplants. So use of tech in ED, which will help in guiding us based on the goal-based resuscitation to see whether the patient requires platelets or whether the patient requires FFP or patient requires clotting factors or anything, or just PRBC transfusion is enough. So it was very insightful, and thank you. So even like just to sum up, JAMA in 2015 has there is a trial, proper trial, which showed tech-based resuscitation is superior to fixed massive transfusion protocol of 1:1:1, and it has reduced mortality as well. And East also recommends, East guidelines do recommend TEG or ROTAM-based resuscitation in particularly trauma, where in peripheral high equity trauma cases. So thank you once again. So at last, I would like to thank the Yashoda hospitals for giving this opportunity. I would like to thank the organizing chairperson, Dr. Srinath, who is the HOD and group head of emergency medicine department of Yashoda hospitals. Organizing co-chair, Dr. Saujanya, who is the HOD of emergency department at High-Tech City, Yashoda. And she is also the president of the SEMI India. And the other team members, organizing team, Dr. Shravani, who is a senior consultant and HOD at Yashoda Somajigoda, Dr. Raghu, HOD at Malakpet Hospitals, and Dr. Malay Mishra, HOD Emergency Department at Secunderabad. So, in case anybody has any queries, please feel free to ask Pranay. He will be there to guide you or help you. Any questions? Okay. Fine. By this, we'll wind up this session, and I'll be happy to inform you that Yashoda Hospitals, in association with the SEMI and Anbai, has been doing incredible job by delivering lectures in emergency medicine topics every Friday. It has been happening since last couple of years, which is in fact very rare. Not many centers in India do that on regularly basis, on weekly basis throughout the years. In fact, like if I'm not wrong, it has been happening since the last 3 years. So I would like to thank the Yashoda hospitals as well as the SEMI for coordinating all this activity. So thank you all.
Thank you.